Hello, everyone. Welcome to this second edition of the AI4Health Share. This event we will analyze how AI is used to streamline medical history taking. Before we start the webinar, I would like to invite you to the participation to the European AI Week, European Artificial Intelligence Week, who will take place for March 14 to March 18 of this year, so next month, and will contain so many interesting events. So yeah, just register on the AI4Belgium website. Alexander Vika from BOSA will also share a link during the session so that you can register. And it is my pleasure to introduce today's moderator, Hassel Mathieu. Hassel Mathieu is the innovation lead at MSD Belgium and is one of the most innovative people in Belgium, with a great experience of leading innovative projects and developing partnerships to promote innovation. Hassel will be our moderator today and will be accompanied by two great speakers that she will introduce. Hassel, the floor is yours.
Thank you, Giovanni. I don't know if I am the most innovative person, but what I do appreciate and that it's important for me is a partnership in the healthcare sector, as the sector is quite working in silos. And so I have the pleasure today to introduce a use case of a very nice collaboration between two doctors, but two doctors working in different settings. So that's a very powerful use case. And I have the pleasure also to introduce Dr. Johan Weigen, who is chief of the Division of Electrophysiology of the Cardiology Department at HASSELT Hospital in HASSELT. And he is also consultant cardiologist for the Academic Hospital of Leuven. Dr. Weigen is chairman of the expert group on cardiovascular disease at the European Union, and he is also member of different prestigious associations such as the Belgian Heart Rhythm Association, Belgian Society of Cardiology, and the list does not stop here, but I will take some time to present and introduce our second guest speaker. On his side, Dr. Van de Steen is by background an orthopedic surgeon and also an MBA. He has been working in the fast-moving consumer goods industry and combines medical with pan-European marketing expertise. He has more than 20 years experience in healthcare consultancy and communication, has been working for companies like Bayer, Terumo, Procter & Gamble, Advanced Bionic Europe, GSK, and so on. So what's very interesting to outline in the CV of Dr. Van de Steen is that he is also co-founder of Little Brain, where he has been coordinating the medical support for medical global brands such as Cervarix, Boostrix, influenza vaccines, and so on. And so under his supervision, several innovative platforms were deployed to offer users a concise view of global epidemiology, clinical trials, and regulatory status. And more recently, Pete has co-founded with Tom van der Put Bingley, and you are going now to discover very concretely what Bingley does offer. So, gentlemen, the floor is yours, and I will take back the discussion in 30 minutes. So I give you back 10 minutes in addition to your presentation to conclude with some questions. Thank you very much.
I will share the screen, Johan. So I hope you can see the screen. You're still muted.
Yeah.
Johan, you're still muted.
You are still all muted. Yes.
Okay. Good afternoon, everyone. Thanks, Hassel, for the nice introduction. I think indeed it's a very intriguing project that we went into. the Bingley project, and it was driven by a need from our department. We can have the next slide. Atrial fibrillation is a very common arrhythmia. It's the most common sustained arrhythmia in adults. And during a lifespan of more than 55 years, 1 out of 3 patients will encounter atrial fibrillation at some point. It's not an arrhythmia without any risk. It's not really life-threatening, but still it has 5-fold risk of increase for a stroke compared to someone who doesn't have atrial fibrillation. And that's why we try to see these patients and treat these patients according to international guidelines of the European Heart Association. In this light, there is definitely place for projects like Bingley or other AI projects. On the next slide. As you can see, this is a very busy slide, but what is very important is that you see the happy face of that gray patient. And that happy face means that the patient has no complaints at all, but still he can have atrial fibrillation. And this is a very dangerous combination. The patient doesn't know and still has chance of a stroke. Secondly, there are the symptomatic patients. They have all kinds of symptoms like palpitations, shortness of breath, but these are sometimes very symptoms that are not really specific for atrial fibrillation. It can also be because of other heart or lung conditions. So there are a lot of people out there, first of all, who don't know that they have atrial fibrillation, and secondly, that they have symptoms but not really defined as I feel atrial fibrillation. And therefore a good system to screen the whole population to make sure that we see which patients on an early phase have atrial fibrillation is key. And then the second thing, after the suspicion and then reaching the right treatment, that's also, that should be fast. We cannot afford to wait several weeks and months for the diagnosis, because in that period, a stroke can occur. On the next slide, you see that we have a very strict treatment option written in our guidelines. So the first thing we do is anticoagulation. So the patients should have blood thinners, so not to have strokes. Then secondly, we will try to get the symptoms under control. And thirdly, the C, we will try to get the risk factors for the atrial fibrillation under control. But that's, of course, not acute. That's more a chronic way of life and medication. So you see there's a lot of people out there with a possible chance of atrial fibrillation, and they need to get the right attention as soon as possible. And that's where the Bingley projects comes in. Next slide, I think it's already for Pete. So maybe I can enlighten a little bit. So it's a screening tool. As I said, identifying patients, referral correct and fast, and the data should be readily available. Go ahead, Pete.
Yes, thank you, Juan. So indeed, the objective was to develop a screening tool to help to identify the patients at risk, to kind of make a recommendation for the GP, the first line doctor, to know whom to screen, and then correctly refer them to cardiologist, ideally sending all the relevant patient data immediately to the cardiologist, so there is no delay in further diagnosis and treatment. So the project has been started with several experts on board, all cardiologists, and the project was sponsored by Pfizer, who came with the idea, brought together this very nice expert panel, and then we were there to develop the model. So if you look at the ideal patient flow for the detection of AF, you will see that there are, in fact, two flows. What Bingley does is to help with the anamnesis of a patient. So we will ask smart, intelligent questions up front to come up with a differential diagnosis and to offer decision support to a doctor. So you can imagine that a patient comes in with atrial fibrillation symptoms, then of course, our algorithms should be able to detect atrial fibrillation and put atrial fibrillation in the differential diagnosis. So that was the first objective, the first thing that we needed to prove. Of course, we have just seen that 1/3 of the patients are asymptomatic. So that means they will not have any atrial fibrillation symptoms, or they come with, for another reason of visit, that can be a repeat prescription or whatever. And then we had to develop a model to see, what kind of questions do we need to ask to assess the potential that the patient has an AF and to make a recommendation to the GP to screen a patient. So these are the two models that we had to develop. The first, of course, is inherently what Bingley does. So we had to prove that we can put AF in the diagnosis. The second one is a model that we had to define. If we put all the information in the dashboard of the GP, then ideally it would, with one click, we should be able to refer all the information to the specialist, who then can then contact the patient and define the subsequent treatment pathway. So if we look at the first phase of the project, so the differential diagnostic approach, so what Bingley does is ask questions based on smart algorithms that reason as a doctor. On the background, we have large data sets that link arguments, and arguments are symptoms or risk factors, antecedents, lifestyle factors that then can be related to a disease. So together with our board of specialists, we looked at all the arguments that were related to atrial fibrillation. And we also defined the incidence and the age distribution of atrial fibrillation. So I will just show you a small movie how Bingley works. So in Bingley, of course, there is a consent that needs to be clicked. And then we ask a reason of visit. If the patient comes with a new symptom, we'll capture the symptom. Once we have captured the symptom, we will then ask, we will quantify that symptom right away. So we always ask for the onset, but then we may ask additional questions depending on the argument. Like here in pain, we'll ask whether it radiates, to where it radiates, when it increases, when the pain decreases, what the intensity is, etc. As such, so a patient can insert all his different symptoms. And the moment he has done that, we will plot it on the disease symptom graph. So this is something you will see appear now on your right. So this is a simplified model where the red bullets are diseases and the blue bullets are arguments that are related or linked to the disease. So we'll plot the arguments we receive from the patient together with age and gender. We make two calculations. The first one is a differential diagnosis with probabilities. And the second calculation is, what question or what argument do we need to ask to optimize this differential diagnosis as fast as possible. And that is also how a doctor thinks. So a doctor would like to exclude as many diseases as fast as possible and remain with a manageable differential diagnosis. We ask that question to the patient. The patient says yes or no. So it's always closed questions. We calculate again and calculate the next question. So you see, it's a completely dynamic system. It's not a structured approach. It's not a decision tree approach. So we ask in total 10 to 15 questions, and then it stops for the patient. So of course, this process needs to be validated for AF. And we have done that together. So we see that over the thousands of patients that we have created and that we have run through the algorithms, if they come in with an AF related complaint, on average, we have atrial fibrillation on the second place in our differential diagnosis, which is very good. And there is a standard deviation of 2. So this was meant to be a good validation of our approach when a patient enters with AF symptoms. The second part of the screening model was a little bit more difficult because we had to develop a model to predict an AF risk, which is not based on symptoms. So how did we do that? So we built what we call a random case simulator, where a computer based on the data set will create virtual patients. And those virtual patients were then sent to our participating panel. And they just saw the patient and they got 3 questions. So they saw the patient, age, gender, they saw the presenting symptoms, possible antecedents, and 3 questions. The first one, is this case a possible real life case? Because of course, when a patient generates a case, a computer generates a case, it's possible it's a case, a patient that realistically cannot exist. For example, a 90-year-old man who just started endurance sporting, the likelihood that ever is going to happen is quite low. So that is, those patients were esteemed to be non-real life cases. Then we asked them, what is the AF risk of this patient, high, medium, or low? And then the most important one, would you screen this patient? And there the possible answers were yes and no. And by offering thousands of these patients to the specialists of these cases, and them answering the question, we received data to train the model. So based on this data, we trained the model using different machine learning models. And we saw that out of the, I think we had around 60 to 70 arguments that are related to atrial fibrillation, we kept around 20. So we had, first of all, real symptoms, and then we had risk factors. So at the end, we kept, I think it's 9 risk factors that were predictive for atrial fibrillation. And we reached, with this data set, we reached quite high precision in our model. So with these 2 exercises, we indeed achieved to create, it's not to create, to create an ideal patient flow. So we have demonstrated that when a patient comes in with symptoms, we are able to put AF in the differential diagnosis and so in the spotlight for the GP. When the patient does not come for AF, has no symptoms, or comes for a completely different reason, we have a screening model that then can ask 2 questions, which I will explain immediately, that can give a screening recommendation to the GP. So it means we have been able to build a model that is applicable to 100% of the patients that come in the first line to screen them. So if you look at the screening questions, we have in fact 2 questions. So if a patient comes in has no AF symptoms, these are the 2 questions that we're going to ask. So it's extremely simple for the patient. It's just a few clicks and we can calculate whether screening is recommended, yes or no. When a screening is recommended, we show it like this in the doctor dashboard. So a doctor has a dashboard where he sees all the patients that have made an appointment with the doctor. And we have an AFib screening column. And a red dot means that there is a patient who is high risk for AF that is recommended to be screened. If then the doctor opens up that patient, he can see the result of the question. So he sees the answers of the patient. He sees a calculation of the risk, and he has a possibility to add information. So the first piece of information that he can add is a cardia test. So Pfizer provides cardia devices to participating GPs, so they can quickly, in 1 minute, screen a patient. So they can insert the date of the test and then insert the test result, which is then positive or negative. If the patient is positive, they can immediately refer the patient. They can add the cardia file by uploading it. They can select the specialist to whom they want to refer. They can indicate whether the referral is urgent or not urgent, and then can refer the patient to the specialist. And a few milliseconds later, the specialist will have the complete patient file and can plan all next steps with the patient. So this is a really, it's a very fast, transparent way of referring patients from the first line to the second line. I will still do this one, Johan, and then I will transfer back to you. So practically, how did we roll that out? So the Pfizer sales reps helped us to create awareness with GPs. And we also organized with the participating specialist GP meetings to present the AF project and to see whether they were interested in participation. So if we look at, for example, the GP meeting that we had in HASSELT with Dr. Vijgen, 60% of the GPs were interested to start this project. So the interest with GPs is quite high. If GPs are interested, they are visited by us to start up the project, and they're also visited by a Pfizer sales rep by whom they receive a cardiac device that they can use to do the screening for AF. So this is the approach to start up in practice. And these are the results to date. Johan, you want to take this?
Sure. It's, of course, a project that is just started at the end of middle of last year. We were a little bit hindered by the Corona or COVID epidemic because the general practitioners were very extremely busy and were not eager to start new projects. But still, we have 28 participating practices, 3,800 screenings, and almost one out of three were positive. There were patients confirmed with the cardiac device, 27 up till now, and 20 were referred via Bigly. The others were treated by the general practitioners themselves. So that means that the screening is possible, it works, that the patients really comply and that they complete the questionnaire, and that the general practitioners will have a device or some procedure to perform that very easily. For our center ourselves, we are cooperating with a few general practitioners up till now. We, of course, are looking forward that this increases a lot. We had a few referrals. 2 patients were screened and not confirmed by the cardiac device. And on the next screen, you see that the first patient was considered positive by the cardiac device, so proven atrial fibrillation in June 2021. And just 1 week after, he already had an AFib consultation. On that consultation, the patient is educated about stroke prevention, about the treatment, about the risk factor management. And he was started on anticoagulation, and 20 days later, he could have his electrical cardioversion, and 1 month later, he could have his catheter ablation. And this patient is doing very well now. The second patient on the next slide, he had a history of atrial fibrillation in the past, but was free of symptoms for a long time, and then he had recurrent palpitations. The cardiac device through the family practitioner showed atrial fibrillation in November. 4 days later, the patient was received in the AF consultation, got the same treatment as everyone there. And 1 month later, he got his AFib catheter ablation. So you can see with these examples that there is a timely detection and a very fast referral and follow-up without too much phone calls and problems getting the patient into the clinic. It's all done automatically, and that's the key, I think. Back to you, Pete. Oh no, that's still mine. So at our meetings with general practitioners, as Pete says, more than 60% are very interested. Of course, in the last months, it was very difficult because the GPs were overwhelmed with work, but it proves that the referral process is uniform. That's also important because there's a huge difference between treating physicians on their knowledge of atrial fibrillation, on their way of treating those patients. So this referral process is uniform, it's very streamlined. And the patients get a very fast, effective plan. So it seems to work both on the screening side and on the referral side.
Yeah, so what we, if maybe to add to what Johan just said, is that we see indeed that patients do comply, so they fill it in, but we see that the uptake, so the effective screening with the GP practices is still quite low. So we're looking how we can increase that. First of all, there's of course a little change management that needs to be done, and of course COVID is there and causes a lot of problems in GP practices, certainly from the administrative part of view. So we're now also looking at maybe, and we will discuss that with GPs, that they will proactively send out the screening questionnaire to their GP. So maybe the consultation can be better planned and in function of a possible screening recommendation. So these are maybe possible routes that we are looking at in the future to increase the adoption of and the efficacy of the tool. Hassel?
Okay, thank you very much. Congratulations. That's a very interesting case linking prevention with therapy and cure, but also the integration, the fact that you are proposing an integrated care pathway to cardiac patients. That's really the future that is already present, and the fact that you propose a very reliable decision support tool to doctors. Now I have some questions, and I see that there are questions also from the audience. Don't hesitate to list your questions in the chat for the audience. So first question would be, as you mentioned, so the adoption by the GPs, there is an interest, but the adoption is limited because of COVID-19. Maybe there are other elements that can enter into play and that might be important for GPs. And I'm wondering, or you are communicating on those elements, or what is your perspective on those elements? So the two elements I refer to are trust and the integration with their existing systems. So and it is linked to a question of the audience, is to what extent Bingley is using standards for being interoperable with existing tools of healthcare practitioners. And the other question related to trust in your solution is, so you have proven here that the standard deviation was low, and but how do have you made a publication, or, and it's a question that I address also to Dr. Wagen, say, is why or how did you start to trust the solution based on AI? Is it because you contributed to it, or yes, or do you build trust with the GPs and the specialists? Thank you.
Well, I'll start, and afterwards I'll let Pete answer it too. First of all, I saw that it's. I started to trust it because we saw it grow. In the beginning, indeed, I must say I was a little bit skeptical whether it would work because we still rely on the one-to-one patient contact. and not on questions asked by phone. But after doing all those 1,000 cases, potential cases, we could see that there was definitely a potential that it would work. Of course, there needs to be a proof of concept, but in the patients that we saw already, it was nailed on. So it was proven that it's working, that it's definitely possible to diagnose and to screen patients and to get the AFib patients out and to diagnose the arrhythmia. And then, of course, it goes their own way, but you learn to trust it while using it.
Okay, thank you, Doctor. And are you planning to make some kind of scientific publication around the case?
Well, not around one case, but I guess if we have used that intensively, I think it would be very nice after, for example, 6 months to see what the results are. But of course, we need to have more patients then and more practitioners joining us.
Okay, yes, makes sense. Dr. Van der Steen, do you want to add something to that question of trust and maybe also on the interoperability of Bingley solution?
Yes, for the interoperability, I will start with that because that's the easiest one. So we adhere to all international communication standards like FHIR or HL7. So that's the basis for integration. So we can integrate. The only thing is that practically it's not always that easy because those are really modern standards and not every system is currently able to do it to the full extent. So, but it is possible. And we do work on these integrations when we are allowed to. We are always asking for integration because it's extremely important in the patient flow. For the doctor, that he stays within his environment and can do everything in his environment. But of course, you also have to deal with the EHRs, and they're not always open for these types of integrations. So it's we see that more and more begin to open up to the possibility, but it's not always possible. So that's for the integration part. For the trust part, I think that, yes, trust is something you earn. You earn that in different ways. We have always believed in a strong cooperation with the scientific community. So that is also how we build the algorithms. So we explicitly did not want to build a black box system where you draw data out of an EHR and then you put them into a model and then something comes out and nobody knows what, how you get that result. So we have a white box system that follows certain clinical rules. It is based on AI though, but it's a different model. And we set up the tool working together with doctors, with specialists to validate the data sets that are behind the algorithms. And we also did the validation with them using vignettes, using Monte Carlo testing to have that validation ready. And that is something that we can, we are proud of. We know we can show in detail how we get to a specific result. And that, of course, for any kind of clinician offers trust if they can look into the algorithm and see why a question is asked. So that is an important step, I think, in the trust. We do not have a published, a publication yet on our results, but we're working on that. So we are working on publication with the Barts hospitals in London. We're working on publication with Giovanni, which is more vignette focused. So more will come, and they will prove that, hopefully prove that the accuracy is as high as we say that it is. But we're quite confident that it will.
Okay, thank you very much. There is also, there is maybe a very specific medical question for Dr. You are both doctor, but for cardiology. Is the algorithm on the chat? Yes.
Yeah, I see it. If the algorithm is more efficient at detecting paroxysmal permanent or persistent AFib, It's actually for all the kinds of atrial fibrillation. It's not specific for one type. It just points out there's a high risk for atrial fibrillation, or there is a documentation of the atrial fibrillation.
Okay, thank you. To come back a bit to the standards, there is a very specific question on the fact that you use the SNOMED CT codes, or to what extent they are embedded in your
Yes, yeah. So everything, all the data that we capture is immediately structured and coded, and that's done in SNOMED CT. So well, of course we have our own data mapping or data structure, but we map everything on SNOMED immediately. So that means also in our data exchange, we use SNOMED. We can map to ICD-10 and ICPC2 if necessary.
Okay, thanks. And now I have a question. It's more regarding the perspective of the patient. So because the patient is not represented here today, so I would like to know through your experience, what has been the experience of the patient? So what is it for a patient to use Bingley? Do you have feedback on the use of by patients? From a medical perspective point of view, yes, if you can also maybe explain a bit what, if you have feedbacks from patients on the use of that new solution.
Well, I can definitely start with the experience of the patients that were referred to me. And maybe we can comment more on the 3,000 patients that use the system already. But on the patients that were referred, they were, of course, very pleasantly surprised of the speed of referral. As you know, getting into a cardiology service might take months or longer, and they were there in 1 week. So they were, first of all, very satisfied with the fast referral. Secondly, with the way we had the patient covered afterwards, because we have a system where it's nurse-based, very knowledgeable nurses that give all the explanation, all the possibilities, and the correct treatment according to the guidelines. So the patients I was referred were very, very happy and impressed by the speed of the referral.
Very great use case. Okay, thank you. And yes, Pete, do you want to add something?
Yes, if we look at patient experience, so we have two sources for that. One, of course, is feedback from doctors. And the second one is also that we ask ratings from the patients after they have filled in Bingley. So we currently have an average rating of 4.3 on 5, which is, I think, quite good. But I think even very good if you look at healthcare apps, because normally healthcare, if you look at EHRs, they don't have really good scores. So I think that's a very good score. If we look, they all always have the possibility to add comments, and we see that if there's negative comments, it's mostly because I think that the flow might be a little bit too long. So that is something that we are looking at to see whether we can reduce the amount of questions that we ask. We currently ask between 10 to 15 questions. And certainly when a patient uses us the first time, it can be seen as taking maybe a little bit too long. What we do see is that when a patient has used Bingley and has used Bingley together with the doctor, that's very important, and also how doctors use Bingley. If the patient sees that the doctor uses Bingley to review the data together with the patient, the next time there is no hesitancy anymore of the patient to use Bingley. So it's very important for the patient to see that if he does the preparation, that the preparation is also used by the doctor. If that happens, there's a reinforcement, and the patient will next time be very happy to fill in all the questions that are asked. Then maybe a second kind of feedback we have is from our clients. So we also have, for example, a preoperative questionnaire that we have in 2 hospitals where really 100% of the patients that need a surgery will have to go through. And we also see that 100% of the patients are able to fill it in. And that's because of two reasons. One is that the interface is very simple and very intuitive. And secondly, and we did not mention that here, but a patient can also fill in all the information in his own language. So that means that as a patient, whether you are Polish or Turkish or whatever, you can fill in the questionnaire in your own language. And then the nurse or the doctor on the other side can just see the answer in his or her own language. So there's a translation on the fly. And that is, of course, in a more and more multicultural setting that we are, extremely important, certainly in health literacy, because health-related information is often very difficult to express when it is not your mother tongue. So that is something that we do take into account.
Powerful solutions. Thank you very much. And sorry, but still a question for you, Pete. It's regarding the business model of Bingley. So do you cover other therapeutic areas? And I also would like to ask you, what's your vision regarding Bingley? So what do you want to become?
Okay. So maybe I will first start with the vision. So what we want to do, so what you've seen here is an example of our dynamic anamnesis. So the very intelligent questioning that we can do. We have seen that covers around 40% of the clinical needs. So to cover the rest, because some question you can also ask in fixed or semi-structured questionnaires, we also created what we call a survey builder, where any clinician can create a relevant questionnaire on the fly. So really, in a matter of a few hours, the questionnaire is ready in several languages. And that makes that we can offer solution for any clinical situation. If you look at the algorithms, we are disease agnostic. So we have, they cover all around 1,500 diseases in all therapeutic areas. So we are not restricted to one domain. And I don't know whether there was a second question. Yeah, and then the mission, of course, the vision. So we really want to be a platform that allows to gather data, patient data, and generate insights for doctors. So that is our vision. Whether they are, we retrieve the data by smart questionnaires or by semi-structures or whatever, it doesn't really matter. We want to gather in a very qualitative way patient information and then generate insights to doctors to help them in decision support, to help them to steer patient pathways, to help them to automate flows, in short, to create efficiency and consistency in processes that currently often lack those items.
Your answer is great because it is linked to one question in the chat to know if you can derive information to manage, for instance, public health matters such as the pandemic.
Yes, so I don't know who asked it, but when the COVID started, based on our approach, we also had the COVID checker, and that COVID checker, of course, allows to immediately see where hotspots are and stuff like that. So it is perfectly possible to do population screenings and aggregate population data and do analysis on it using our platform.
Okay, thank you. And still one question related to the use of Bingley. So is Bingley used for emergency and in emergency wards?
Yes, that's a very good question. It's one of, I think, the nice examples or use cases that we currently have. Of course, the use of Bingley in the ER is a little bit different because you cannot ask the patient to fill in everything in advance, so the patient will fill it in the waiting room. So practically how it happens with most of our clients is that there's a quick triage by a triage nurse, so that the very urgent patients, they go to their box, and all the rest they go to the waiting room. And then in the waiting room they get a link. So the patients in the waiting room get a link to Bingley to do the anamnesis. And then it has a double function, of course, is to gather information data, but also keep patients busy while they are waiting. Patients do not like to wait. And we know that patients really get frustrated when they have to wait a long time. So it's better to keep them busy in a very useful way. And then the moment that we have gathered the data, we already give it to either the nurses or the doctors to perform, for example, triage. If there's any, I would say, diseases with high potential morbidity or mortality risk, we can put red flags, orange flags, and they can do triage based on that and get people maybe earlier into the box, or maybe even refer patients to back to, I would say, the first line if it's something very benign. So it offers a way to do fast triage in the emergency room setting.
Okay, great. Very clear answers, very nice discussion. And I thank also the audience for the relevant questions. I have maybe one final question for Dr. Wegen. So, because I know that it is a matter that is important for Giovanni, to what extent do you believe that this kind of solution should be included in the cursus of specialists? To what extent do you believe that there should be more maybe linked toward those technologies in the cursus?
I think it will be the future eventually, but at this moment it's all, let's say, loose projects. There's no general vision on what AI or computer modeling will mean in a few years, and it definitely will mean a lot. So at this moment, it's probably not easy to give a course on that in the education of specialists or medicine. For example, we have two doctorate fellows who are specializing in the application of AI in cardiology, but they are still looking what the possibilities are. And of course, their presentations are always very, very nice. All the cardiologists are very interested when they present something, but there's no unified vision yet on what AI will mean. There's something in echo, there's something in ECG, there's something in screening. So the education, the medical education, they should become aware that these things will come, but it's very hard to give a concrete course yet.
But at least you gave a very interesting use case today on the use.
On how to do it.
Yes, exactly. So I don't know if there are still questions in the chat. I don't think so. Do you still want me to ask a last question, Giovanni, or do you want some time to speak about, to present new initiatives of AI4Health?
I believe we have time for a last question.
Okay.
Okay,
great. Then, Dr. Wegen, still one question. It's regarding the how easy it was for the hospital in which you work to start looking to explore a use case with a startup company. Was it easy from, I would say, maybe more legal compliance process?
That's of course extremely important that it's GDPR proof and that it's okay from a legal point of view. We looked into that definitely. Now we are already organized in that way. We have an atrial fibrillation clinic, really according to the guidelines, with nurses that run this. And that's why when we get questions, we check it with the hospital, and there were no objections. after GDPR and contracts were reviewed, of course. There is definitely a need to run these projects by the administration. You cannot start this like a test and not comply with the regulations.
So it's feasible from an administrative perspective, and you did it. So congratulations. I think I will.
Maybe I will add one thing to that. I think that the connection was really fast, and I will also answer to another question in the chat, because we are indeed classified as a medical device, class 1 for the time being, going to class 2A. But we're also ISO certified, we are GDPR compliant, we work with the DPO, we follow the contracts. That's from the hospitals themselves. So that of course facilitates working together or the integration into hospital systems.
And it has been a long process, I imagine. Or
yes, it's long processes. It's costly processes. But of course, privacy, security, and GDPR are important elements in as we work in healthcare-related data. So I think it's also normal that we comply with it and do the effort to be up to standard.
Of course, and I assume that it requires some adaptation with the new MedDev regulation from your side, or was it?
Not really, because we started when the regulation was already announced. So it means that we were able to take all the requirements, to build them in as from the start. So for us, we knew it was coming, and we were prepared.
Okay, so it's feasible to be in line with the new medical device regulation if you plan it.
Yes, yeah.
Mm-hmm. Thank you very much to both of you, and congratulations with this very nice use case impacting positively cardiac patients. Giovanni, I will refer to you to close the meeting. Thank you.
Thank you so much, Hassel. Thank you so much, Pete. Thank you so much, Johan, for a very interesting session. As a closing remark, just to complete what was said before, I really do believe that we have to educate future medical students in the topics of artificial intelligence and digital medicine. We can do it. Medical students they have the necessary knowledge, they have the necessary skill, and it will allow us to improve the way we carry out innovative projects such as this one that you just presented. So thank you all very much. Thank you, Hassel, for this very nice moderation, and thank you to the audience. Just to announce the next AI4Health chair. So it is my big pleasure to announce that the next chair, which will take place during the European AI Week on March 17 at the same hour as today, that is 5 p.m. I have the pleasure to invite my friend and mentor, Professor Olivier Lemoine from Hôpital Erasme, and Ségolène Martin from Quantify, that will discuss about clinical decision support system in hospital electronic health record. So stay tuned. We'll let you know how to register in the link. You have been quite a lot following us on YouTube today and on Zoom. And I would like to thank once again very much our speakers and our moderator, and we'll welcome you again next time. Thank you to Alexander Vika from BOSA for the support, and very nice support during the session. Nathanael Ackerman, the general manager of AI4Belgium, couldn't join us today because of another meeting, but he will be there at the next one. And we thank once again also Numericaire, which is our partner for the dissemination of invitations to medical doctors and so on. So yeah, thank you, and see you soon, and have a nice end of week and weekend. Bye-bye.